Our mission is to help the least served improve the mental, the physical, and spiritual health. That is our mission, the least served. And so we have programs and services in reaching 72 counties. So every day, our staff and the people we fund, they see the faces of the uninsured, the people who are falling through the system every week, every month, every year. And so that's what we bring here, saying, why is this occurring? Why is so many people who are uninsured falling through the cracks? So in order to try to understand what's occurring, what can be done, we commissioned several studies to try to understand the extent of the problem that we see every day. And so we've also been noticing that a lot of the problems, they occur at the local level. So we want to do studies and commission reports that focus at the county level, because even though there are state policies, they're seen at the local level. So we met with Dr. Murdoch and Dr. Klein before the healthcare reform was passed, and we said, okay, what can we do to get prepared for this important change that's coming down? And that's what we evolved the study that we'll be talking about. And then based upon that, then we said, well, then what's going to be the further impact? What other ways can we use that information? Because we also noticed that, especially in the rural counties, there is not the capacity to handle the needs right there in the communities. So I was at a conference in DC, and I saw Dr. Koo present on the medical capacity of the different states in the United States. And then so I went up to him and said, can you do that for the county level? And then that's what he did. We commissioned him to look at the impact of healthcare reform at the county level. Right now he's at the Appropriations Committee. We're seeing if we can get him and Dr. Murdoch and Dr. Klein ask some questions during the appropriations. So we're juggling people back and forth. So then once we have this information and we have the studies, we also say, okay, what do we do? And we work with the Center for Public Policy Priorities for many years and many projects. So we then partner with them to say, let's take this complicated data, how to present it in a format that can be easily distributed with policy, with some policy recommendations, and seeing how can we get that to people who can make a difference. So that's what we have been doing, and that's why we're here. We're here to see how we can help the people who are falling through the cracks. And with that, I'm going to turn it over to Ann, and I'm glad you all are here. Thank you.
Thanks, Ed. Well, we're going to have a few introductory remarks from Dr. Steve Murdoch, who almost all of you are familiar with. Dr. Murdoch is the founding director of the Hobby Center for the Study of Texas at Rice University, but most of us in the audience also know him as our former Texas State demographer and the former director of the U.S. Bureau of the Census. At the center, we are extremely grateful to have him also serve on our board. He's quite a valuable board member, as you can imagine. So he's going to tell us a little bit about their role in this project before Dr. Klein comes up and lays out the nitty-gritty of the details. Thanks.
Well, thank you, Ann. It's a pleasure to be here, and for all of you that know about me, I can promise you that I will not be providing any set of about 50 or 60 tables for you to digest in the next 2 minutes. But you will have to excuse myself and to Dr. Klein that's coming up, because we are both demographers, and you know that demographers tend to get preachy. But we have a right to do so, because unlike many callings, demography is a divine calling. Now, we know it is because there's a book of Numbers in the Bible. It's all about censuses. Check it out. You'll see that I'm correct. Well, as Ed said so well, we began to talk about the issues of what would happen if the Affordable Care Act passed in late 2009. I think we began our discussions. And we began to see it, I think, of utility from both a demographic and a social service perspective, and that being that obviously if you read the Act, you see it kind of lays out certain subgroups of populations that are affected in different ways by the Affordable Care Act. And then, of course, there are policy issues related to what happens to each of those subgroups and subpopulations. So we are demographers, but we knew some people who were very good in terms of public policy, and so we partnered with David Warner from the LBJ School and a colleague of his, Lauren Jenke, and therefore contracted with Methodist Healthcare Ministries to do an analysis really of who will be covered and who will remain uncovered, if you will, by the Affordable Care Act. I think already, having been around the Capitol a little bit today, our estimates might be somewhat higher than some I've heard in terms of what's happening. I think, frankly, ours are better, but I'm a little biased. But enough of me. I'm going to introduce Mike Klein. Mike Klein is the Associate Director of the Hobby Center for the Study of Texas. I'll say only one thing about Mike, and that is I've been around a while. And I've had lots of people work with me, but Mike is absolutely the single best and most competent person that I've had working with me. So with that, I'm going to introduce Mike Klein.
So I guess I can ask for a raise then? Let me make sure, okay. Thank you very much, and I'm fortunate in not only being able to kind of work on this research project, but also know a lot about Methodist Healthcare Ministries, because I actually, when I was in San Antonio, I was a member of a Methodist church, and we actually had services that were funded by Methodist Healthcare Ministries, so I see kind of the face of what Methodist Healthcare Ministries does, and then also get an opportunity to do this from a public policy standpoint, looking at the impact of the Affordable Care Act on Texas. Now, when we started this, as Ed and Steve talked about, this was really before ACA was passed. We started looking at it even in the deliberations. So in many ways, we didn't know what the policy would look like. And then once it was passed, I think even today, we're still wondering ultimately what the policy is going to look at. We know a lot about it, but there's still some uncertainty. And certainly if you look back into the 1960s, the biggest policy change was Medicare. And even with Medicare projections, basically that was a new framework, and we didn't know what was going to happen. So I think in many ways for ACA, we're seeing the same type of thing. We're doing what we can to best look at the impacts, but still, this is a new paradigm. Ultimately, what we were tasked to do is look at the potential impacts of the ACA for Texas and Texas counties, and specifically look at changes in the healthcare insured or uninsured population for the state and counties. So that's our main focus. We weren't, although we look at different groups, because of the policies, we were really focused on, so who remains uninsured? The major provisions of the Act: there's a health benefits exchange, added insurance mandates and penalties to have coverage. There's a Medicaid expansion that's being discussed today. Young adult coverage: individuals 19 to 25 can be covered by their parents with certain restrictions. There are also tax credits for small businesses and nonprofits, and some insurance reforms like not dropping people for pre-existing conditions. So there's several different things that impact the insured, but the two major changes that we see, and looking at Warner's and Jenke's work, the two major things that will impact the uninsured and the provisions are the Medicaid expansion for adults less than or equal to 138% of federal poverty level, and also the health benefit exchange available to people 100% to 400% of the federal poverty level. You've probably seen, if you're involved with healthcare policy, you've probably seen this slide in many different forms, but it just shows you the changes from the ACA in public coverage. Blue being the current Medicaid, people currently covered by Medicaid. Red being new Medicaid, changes to new Medicaid, which some children that are currently covered under CHIP will be covered under Medicaid. And then the main change is the adults, 19 to 64, that are now be covered up to 138% of federal poverty level. So we as demographers looked at this from a demographic perspective. We looked at it from, so we know these groups are going to be likely to be impacted by the ACA. So the best thing that we could do was to estimate those different groups. And then from those different groups, look at different changes in insurance rates at the state level, and then bring that down to the county level. So we estimated 11 different groups, and we estimated these by ages 0 to 18, 19 to 64, and 65 and older, and to add some variability in the insurance rates insured of these groups, also estimated by different racial and ethnic groups. Our main data source was the public use microdata sample from American Community Survey. We actually looked at the 2005 to 2009 data set for these different groups, but for the insurance part, just looked at 2008 to 2009. That's because ACS only started asking health insurance information in that time. The American Community Survey occurs every year, and the public use microdata sample represents a sample of about 1 in every 11 households. What is good about this sample is it provides us a way for estimating groups in regional areas and down to the county level, or gives us a better estimate, so to speak. The smaller area you have, the larger errors you have in estimates, so that's kind of what we're trying to do, is to get the best estimate we could for local areas. Then we looked at 3 different policy scenarios, ranging from a high scenario where we basically said for most groups they'll be covered at 98%, either through private or public insurance. This is similar to or the same as the population that is currently covered by, mostly by covered public insurance, and that is the Medicare population, 65 years and older. On the other end is a limited. We assumed that there would be there would be some some people responding to the different mechanisms provided by the ACA, but that there would be very small efforts by the state and other policymakers to implement both Medicaid expansion and the health benefit exchange, and individuals would would have limited response to the different mandates and penalties. Our moderate scenario was somewhere in between, and our moderate scenario is what I'll focus on because that's closest to most other state level analysis from the Congressional Budget Office, RAND, Robert Wood Johnson, and our Texas Health and Human Services Commission. So again, just some of the groups that have little to no impact. The elderly, 65 years and older, are already covered at 98%. The undocumented are not impacted by ACA. They're not currently eligible for public health insurance, and they still will not be eligible for public health insurance with the exception of emergency Medicaid. Nationally, the best estimates from Pew shows that these undocumented is covered about 40% by private health insurance, and so we use that same estimate. And then some of the recent legal permanent residents have limitations on public insurance eligibility. We also pulled out a group. This is really mainly for us to be able to estimate at the county level. The group that is insured at a much higher rate than most other groups are people employed in government, and so we estimated the individuals employed in government, and that allows us to focus on the other groups. Children, less than 200%, well, go over adults and children 400% or more federal poverty level are not eligible for subsidized coverage in the exchange, nor will they receive public insurance. And so there's little change to that group. We estimated 11 different groups, but here's some of the groups that will see the major changes following ACA. With full implementation of ACA under the moderate scenario, the uninsured population would change from about 5.9 million uninsured in 2010, declining by almost about half to 2.9 million following full implementation of ACA. And that translates to currently insured in 2010 of 77%, to the moderate scenario of 88% insured following ACA implementation. And if we just look at the childhood population, there's a change from about 18% uninsured in 2010 to only 8% uninsured following full implementation under the ACA under a moderate scenario. Again, just looking at the different policy scenarios from current to the enhanced. And our focus was also not only on the state level, but looking at the counties and the implications for the ACA on county impacts to the uninsured. If you look at the uninsured for the counties by different county type, central city counties have the highest rate of uninsured, and the statewide average is about 22.5, central city counties at 23.7. And under the moderate scenario, central city counties would change to 11% uninsured, with rural counties changing to 10% uninsured. In many ways, the two groups that will be impacted most are rural counties and central city counties. They currently have a higher rates of uninsured, and we'll have the most to gain under the ACA. And just give you a picture of that change. This is the moderate scenario, percent of the population uninsured following ACA under the moderate scenario. There are 37 counties that will have populations, or 12% of the population uninsured following full implementation of ACA. Now the question may come, well, why are there still higher rates for some counties than others? And that is because of the nature of the groups estimated in those different counties. Counties with higher numbers of undocumented and higher numbers of population that are below 138% of federal poverty level are likely to still have higher rates of uninsurance relative to the other counties. And with that, well, I do want to speak to, I want to say some caution. We did this study and completed the study before the Supreme Court decision. And so we really weren't, even though we looked at Medicaid population, that wasn't our main focus. Our main focus was to look at the impacts and the change of the uninsured following full implementation of ACA. However, we did look at a group that is likely to be impacted from Medicaid expansion, or will be impacted, and that's adults less than and equal to 138% of federal poverty level. And if you look at that population, in 2010 there were 2.5 million people in that eligible population. In 2010, about 1.2 million were covered by either public or private health insurance. And with that moderate policy, 935,000 would be added to that insured population. Again, it could be in public and private health insurance coverage as well. So it's not necessarily direct Medicaid expansion, but it is that eligible group. there are certainly limitations in trying to forecast a future with a new policy paradigm. And as I said earlier, we finished this project before the Supreme Court decisions. We did not look at variability in local insurance rates, except to say that we looked at the different populations within each county. And even though we have some estimates of the undocumented, that is a difficult population to estimate just because of the nature of that population. Thank you very much. Turn it over to Ann.
I think since I'm going to ask you to stay here for just a second, and if we have a couple of questions for Dr. Klein that are burning right now, we can go ahead and take them. We'll also do some more Q&A at the end of the whole program. So, Mr. Denton.
What's the, what time frame, over what time frame are you predicting the 900,000 Medicaid expansion?
Yeah, and I probably didn't spend enough time on that. Because there were so many different moving parts, we looked at 2010 population and said, if ACA were in place today, how would that change? In full, it was full implementation in 2015, but with a 2010 population. So that's what we looked at. So there's certainly, with increasing population, there will be some increases from that point.
Anything else right now?
One quick thing.
Good.
Mike, would you kind of tell them the total numbers that would be now insured versus what would have been before? Both adults and children, I think you.
If we looked at the non-elderly adults, 19 to 64, currently there are about 15.3 million people in that population. 10.8 were insured in 2010. Under a moderate scenario, 13 million would be covered, and that's translate to 15% uninsured. For the childhood population, about 6 million insured, and with the ACA, 6.7 million would be uninsured, which would mean that 8% would be uninsured following ACA implementation.
I have committed to memory these numbers because we had to make infographics out of them. So I think and I can see the infographic in my mind that our communications folks did. So if we, at the moderate scenario, our uninsured rate drops, about 3 million people gain coverage, so it more or less cuts it in half. If we had robust enrollment, I believe about 4.5 million people gain insurance coverage. So I see suddenly a lot of hands have popped up. I'll probably take just a couple of questions and then we'll move on. Put your hands back up. Oh, okay. Stuart.
Did you look into the reasons why the valley, the borders, still had high uninsured rates?
It's basic. Well, it's the nature of the populations in the counties. So you have counties that have, even though you have a much larger poor population, people in poverty. And not all those are going to, even if they're eligible, or not all of them are going to still want to be covered by Medicaid for whatever reason, or may not be covered by Medicaid for whatever reason. And also, if you have a larger percentage of undocumented or recent immigrants that are not covered by private insurance, there's no public way for them to be covered.
A lot of employment there is in relatively small companies.
Right.
And we're not sure at all that those companies are going to be able to come forward to insure the populations.
Take one more.
All of this assumes that the federal taxes accept Medicaid money that is being offered to them by the United States government, right?
Right. Yeah, this was before any sort of debate over Medicaid expansion, except I would say that if you look at, I've looked at some of the estimates from Health and Human Services, and they're looking at that Medicaid expansion, and our limited scenario is actually slightly less than their scenario when they're looking at their Medicaid population. So, so we weren't looking at that specifically, but our limited scenario, I think, would be a good proxy for the Medicaid question.
I wanted to point out that the summary piece that the center did, summarizing this particular piece of research, which is out there on the table, the copies are there, that's one of the things we tried to drill down on because we did have the luxury of putting that together after the Supreme Court ruling. So we pulled out the focus that they did on kids below 200% of poverty and adults to 138% and have some general numbers on that. And basically at the moderate scenario, it appears that those two income groups account for about half the coverage game, just under half, about 49%. So the big take home is that without the Medicaid expansion, we lose about half the gains that they've modeled. I think I'm going to let Dr. Klein sit down for now, but he's not leaving the building yet. And I do want to point out, if you haven't already connected the dots on that, that the center was able to use their county scenarios in the county fact sheets that we put out last September, where we used their enrollment numbers, including the sort of proxy estimate for how many fewer people get coverage if you don't do the Medicaid expansion, as well as the Health and Human Services Commissions of the actual dollars that would flow through the state economy over the next 4 years if we do the expansion. I want to point out then that Dr. Koo, who will be doing a presentation right after I do a little quick update on where we are with Medicaid expansion, also used their county numbers to take a look at what's happening with our primary care provider supply in Texas, but also importantly, Billy Hamilton Associates in the study that he recently released with Texas Impact that was also commissioned by MHM also used that county model. So it's been an enormously useful set of numbers for all of us to work with, and quite a luxury to have people with such good credentials working on that. So can't express our gratitude enough. I'm going to just do very quickly a run through sort of where we are with Medicaid expansion, just in case, because that is sort of did become the wild card in this. Again, they started this model before anyone ever dreamed that there would be an option for Medicaid expansion. It was just supposed to be part of the plan. So we'll just very quickly run through a couple of slides on that before we go on to hear from Dr. Koo. Oh, and I forgot, I've got the clicker. Let's see what we got. So I just always like to remind folks, here is our uninsured population. This is using current population survey data from the census, and it's just important to note how heavily concentrated our 6.1 million uninsured are at low incomes. This particular data set, they have nice breaks at 150% of poverty and 125, so I don't have the exact proxy for your Medicaid, but you can see that the folks below 150% of poverty account for more than 45% of our uninsured. This is a recent data set that reflects all of our who's in Medicaid today as well as in CHIP, and I think it's important in helping you understand what's so significant about the Medicaid expansion potentially in Texas. So our Medicaid program is mostly children. If we had this month's data, it would be more like 2.6 million children. There's around 600,000 additional children in the Children's Health Insurance Program. But in terms of adults in Medicaid today, the two big groups are people with very serious and generally permanent disabilities and seniors with incomes below poverty. Then you have two very small groups of parents. So, and those are folks actually getting cash assistance or recently graduating from cash assistance, and another group of parents who are just as poor as those parents, but they aren't actually getting cash assistance. So in August, we had 2.5 million children getting Texas Medicaid, but only about 225,000 of their parents qualified. So that's a big group that the Medicaid expansion affects, is the parents of the kids we're already covering. Then we also have our very important maternity group in Medicaid that is temporary coverage that expires after the baby's born, but it's responsible for financing, at the last count by HHSC, 56% of the births in this state. So this is another way of sort of drilling down to why there are so few parents getting Texas Medicaid. So the federal Medicaid program doesn't provide for covering adults if they're not disabled, they're not elderly, they're not pregnant, and they're not parents. So they're not in this picture at all. But those two little bitty bars in the middle are the income caps for parents on Texas Medicaid if they're not working, and that one is about 12% of poverty, and if they are working, they get a generous $120 a month earned income disregard. So my mother with two kids, my family of three, whose has a job and gets that earned income disregard, if that mom earns more than $4,000 a year for her family, she doesn't have, her income is too high for Texas Medicaid. So this is how you end up with a program that's covering 2.6 million kids and only 225,000 parents. And I'm not going to walk through this chart. The point is just there are building blocks for the coverage structure in the Affordable Care Act, as Dr. Klein pointed out. It was designed with an assumption that the poorest folks would be picked up by Medicaid in a program that would be affordable and have very limited cost sharing for them. And so when the Supreme Court essentially pulled out that Jenga block, it really creates a problem in the states where it doesn't happen. If you look at the Murdoch and Klein estimates, if you look at HHSC's estimates, the range of adults potentially eligible for this new coverage estimates range from 1.3 million to 1.8 million. Everyone assumes, of course, that not all of the eligible folks enroll. Our Health and Human Services Commission is projecting that just over 1 million of these adults will enroll. Some of you who may have been listening to the hearing earlier know that the LBB is a tiny bit lower than that, but they're very close to 1 million by the second or third year. And then the Health and Human Services Commission also projects that about 400,000 of the children who are uninsured today, we have 1.2 million uninsured Texas kids. We think about half of them are eligible for Medicaid or CHIP right now but not enrolled. And the commission is thinking that about 400,000 of those kids would be spurred to sign up by what we call the welcome mat effect, that all of the information and outreach, particularly if we do the Medicaid expansion and their parents are signing up, will bring in a lot more kids. So these are kids who are eligible today. ACA didn't change their eligibility. We just think that they're going to participate in higher numbers starting in 2014. But if Texas opts out, then we have a problem, again, because the law, was not designed to have an alternative source of coverage for people below 138% of poverty. Just by sort of a fluke of drafting, the health insurance exchange premium subsidies don't start until the poverty line. So literally, if we don't do Medicaid expansion, then in January 2014, we'll be launching our health insurance exchange. People from the poverty line up could be able to go and apply for sliding scale subsidies and help with their out-of-pocket costs, but there would be nothing there for the folks below poverty. And of course, the offset of that is that the costs of care for uninsured poor Texas adults will continue to be carried the way they are now by local property tax payers and charity care providers, and without the benefit of the 100% federal financing in the first year is phasing down to 90%. This is a graphic that probably the folks a few doors down have also looked at today. This is from our Health and Human Services Commission that they've presented to the legislature. And they've done a nice job here with this bright yellow block of showing that if they don't do the Medicaid expansion, this group here of adults is just simply left without a coverage option. We don't have an alternative for them. And I think that you guys are pretty familiar at this point, but just to run through it. As you know, the federal government pays 100% of the cost of coverage for the first 3 years for the expansion adults. It starts phasing down, and in 2020, we have a 10% share, and it's supposed to stay flat at 10% from then on. And then we've already talked about that increased welcome mat effect. Now, the kids in our existing program, we just get the regular match rate for. They did not see fit to reward states that had done a poor job of enrolling eligible children by giving them an enhanced match rate for getting kids in covered that they were already supposed to be covering. So that is a real cost to the state, certainly one that as a children's health advocate I welcome. These are the HHSC cost estimates. They did projections over 2 biennia, basically, and they said for our adults, the GR cost would be about $1.3 billion, drawing another nearly $24 billion in federal match, and then additional costs for the state, for the children, those welcome mat children, which don't draw as generous a match. Our Legislative Budget Board is doing a more conservative model, and they have, but it's not wildly out of sync, but they are not including any administrative, or some of the, as high as an administrative cost estimate as the HHSC is in these estimates. So they're actually saying that for the upcoming biennium, the state would only need $50 million in GR and would draw down about $4 billion in federal funds just in 2014, 2015. This is another graphic from our Health and Human Services Commission, and I think what's helpful about it is it shows that this big red bar is the existing Medicaid program and the state dollars we put into it. And the sort of turquoise bar that you can see up there, That is the only additional GR that they are projecting, state dollars that Texas has to put into Medicaid over the next 4 years if we do the Medicaid expansion. So they've done a good job of illustrating, yes, there's some money there that comes in, but relative to the size of the program, it's very little, and relative to the size of the federal funds that we're drawing, it's rather small. And I'm not going to go into detail about these numbers. I mentioned earlier that one of the first uses after Dr. Kuh's use of the Klein and Murdoch data was some county fact sheets that we did using HHSC's numbers and their numbers about how much money gets spent by county in Texas Medicaid. And the amounts of money that some counties would get are pretty astonishing. That in Harris County, which is of course the largest in the state, over $935 million more federal dollars every year over the next 4 years would be expected to flow through the healthcare economy if we do the Medicaid expansion according to the HHSC numbers. So before I sign off, I just want to mention this is sort of, because the numbers are so big, the people who could benefit are so many, the economic engine is so strong, and the lack of feasible alternatives for this population is such a factor. You do have lots of Republican governors adjusting their positions and deciding to move toward Medicaid expansion. So just within the last 6 weeks or so, we've had all of these Republican governors saying that they are moving on the Medicaid expansion. And from the Kaiser Foundation at the bottom of the page, so we're currently at a point where we have 27 clear supports, 17 oppositions, and 7 weighing options. But I would point out that Texas is one of those states that's in the opposition category, and I think there's a lot of other states that are where we are. There's a very vibrant discussion and debate and educational process going on, and so it's certainly way too early to weigh out, but this is what they're basically reflecting what the governor's position is in this chart. So I think I'm going to go ahead and move on to the next part of our presentation. As I mentioned, one of the first uses of Dr. Murdoch and Klein's data was Dr. Leighton Kuh went and used that information to do some work on primary care access in Texas. I have known Dr. Kuh for quite a long time. He is currently professor and director of the Center for Health Policy Research in the Department of Health Policy in the School of Public Health and Health Services at George Washington University. One of the reasons he got pulled into this work is that, as Ed mentioned, he is the author of an article that was published in the New England Journal of Medicine in 2011 about the challenge of securing primary care for an expanded Medicaid population under the Affordable Care Act. So I'm very delighted to have Dr. Kuh here today, and he's going to come up and talk to you about his research.
Thanks, Ann. Thanks to all of you for attending. You're missing an interesting session down the hall, but hopefully we'll make this one better. This is more gripping. But anyway, let's see if I know how to do this. So this is who I am. We'll talk more about it, but let's get to the gist of this. Is first of all what I'm here to talk about, and I will say this is a subject that came up a lot in the appropriations hearing that I was just at, was talking about primary care and what's the role of the primary care capacity that currently exists in Texas, and the notion that it is a little fragile, and it is. So let's start off with what we mean by primary care. So primary care, here I'm saying, this is the frontline medical care that people get, and it's by people like internists, family and general practitioners, OBGYNs, pediatricians. And I'll say in our study, we also included nurse practitioners and physician's assistants who provide a fairly substantial amount of care on the front lines. And the reason we care about this, and the reason, as we've heard over many years, people talking about ways to improve the healthcare system, is because people realize increasingly that if you have effective primary care, that not only is this what typically people think of, who's their doctor, or who are they seeing most often, but in addition, if you do that well, you can help control chronic diseases, which are ultimately the things that really sort of drive people's main healthcare needs and the main healthcare expenditures. So if you help people control their diabetes, control their heart conditions, et cetera, you can, essentially speaking, reduce the need for expensive emergency room care, for hospitalizations, and so on and so forth. And so this is something that, in general, in the healthcare system, more and more, people expect to see a greater reliance on primary care. So right now we need to worry about, and in Texas in particular. There's an insufficient primary care capacity in many cases, and other places across the country. This is an issue and will become more of an issue over time. In general, you have low primary care capacity. And here what I mean by capacity is how many primary care providers do you have relative to the size of your population and what sort of medical needs and demand for care that population has. If you have low primary care capacity, then what happens is that essentially speaking, people can't get access to a primary care doctor or a nurse right away, so they have to wait a little longer. In many cases, particularly places like Texas, you basically can't find someone close by, so you have to travel 1 or 2 counties away just to get care. Now, the net effect of this is that care is delayed or skipped. And so some practical things that we understand is if a child doesn't get vaccinated or an adult doesn't get vaccinated, then they may end up getting the flu. Sometimes they don't, but this is a risk that happens if, again, there's been that barrier to basic primary care. If people can't have effective care for diabetes or for heart disease, they may end up having a more serious attack, like a heart attack or diabetic problem that ends up in the emergency room or in hospitalization. If a woman can't get a mammogram on a timely basis, then her breast cancer might not be detected on a timely basis. So eventually she can have a very poor outcome. So these are serious issues. Now Texas has a very serious problem. In general, when we look across all the states in the country, Texas is second only to the state of Nevada in terms of, in general, how many primary care providers there are for its population. So not a very good situation to be in. But it's worse in many parts of the state. So there are 29 counties that have absolutely no primary care providers whatsoever. And in fact, about a quarter of the state has fewer primary care providers now than they did 10 years ago. So this is a situation that is bad in general in Texas, horrible in some places, parts of Texas, and often getting worse. So again, it's both an overall problem of primary care supply as well as some serious distributional issues. So a number of places in Texas and organizations have recognized this as a problem. There had been a 2012 task force in Texas that sort of was calling itself the Code Red Task Force. The Texas Higher Education Coordinating Council put out a report on this. Even Texas Speaker Joe Strauss sort of recognized the problem, asked the House Committee on Public Health to think about this issue and make some recommendations. So here's what we tried to do at George Washington University. And by the way, I should mention, for many people you hear, someone coming from Washington, D.C., this is the worst thing on earth. You can say that. I actually grew up in Texas, so, I have some roots here. So I grew up in San Antonio. So I'm still partly a Texan. Anyway, so what we tried to do is really sort of do the most comprehensive study that anyone had done heretofore in terms of examining the primary care capacity in Texas on a fairly detailed county-by-county basis, thinking about what's the situation now and what would it be like if the Affordable Care Act were implemented. Now, what I will say is when we did this study, no one knew about that Supreme Court decision that would make Medicaid expansion optional. So we were assuming Texas, like all the other states in the country, was going to go ahead with the Medicaid expansion. Of course, now this is a big question. Is that going to happen or not? But so anyway, the thing that's probably important to recognize is that we tried to sort of look at primary care capacity. Again, we were taking a fairly comprehensive look. So we looked at people who were medical doctors, osteopathic doctors, nurse practitioners, and physician's assistants. We used data that was reported by the Texas Department of Health Services. And probably the real innovation was that we were trying to measure primary care capacity relative to what the national average is. So we weren't trying to set up an artificial number that says this is how many is right. I don't necessarily know that anyone knows exactly what the right number of doctors or nurses is, but at the very least this gives you a sense of how is Texas comparing to the national average. So for example, we're going to have numbers, and so if I say something like this county has 90% capacity, what that means is that relatively speaking, relative to the national average, this county has about 10% fewer primary care providers than a similar county that has a similar size and similar level of insurance coverage. Now, some other things that are probably just worth thinking about, sorry, because I'm an academic, I always sort of feel the need to have all these caveats. So we're measuring primary care capacity. And primary care capacity is how many doctors and nurses there are to provide care. That doesn't necessarily mean that that's the same as access. You know, so for example, here in Travis County, we estimate that there is adequate primary care capacity. There are enough primary care physicians and nurses in Travis County and many other of the big cities in Texas to serve everyone. This doesn't mean that everyone in Travis County or everyone in Bexar County or everyone in Harris County gets access to care, because there can still be people who don't have access because they're uninsured, because they have transportation or language barriers, or also things like, you know, they can't find a doctor who'll take their type of insurance. So these are other things that get in the way, but you have to have that capacity first. If there's not the capacity, you can't serve them. So in addition, what we measure using economic terms is we think about what's the demand for care. And much of the demand is affected by insurance. What happens is when we look at studies across the country in general, people who have insurance demand about twice as much ambulatory health care, that is doctor's office health care, as people who are uninsured. This doesn't necessarily mean that they need more care. Sometimes they may need different care or whatever. But that because they have access to insurance, they go out and they seek it more often, whereas uninsured people, again, have that barrier. So again, there's a distinction between the demand for care and the need for care. These can be quite different. The other thing to bear in mind is sitting in the background of all this is that Texas has the highest percent of uninsured people in the country. About a quarter of Texas's population is uninsured. This is compared to about 16% as the national average. So what we found when we did our analysis is that in general, the statewide average primary care capacity in Texas right now, or actually I should say in 2011, was about 86%. So it's about 14% below the national average. You know, if I were a professor grading this, I'd say Texas is getting, you know, maybe a B minus, maybe a C. Not a great grade. Now, however, it gets scarier when you look on it at a county-by-county basis. There are 35 counties in Texas that have what we called an adequate level of primary care capacity. That is, they were at or above the national average. There were 70 counties that were underserved. That was between 70 and 99%. 67 that were very underserved, so this is 50 to 69%, and 82. So, you know, this is roughly speaking a third of Texas counties were severely underserved. This is below 50% capacity. So, you know, those are the areas that have the deepest problems in terms of getting primary care capacity. Now, in addition, we also looked at what's the situation for a so-called median county. And what I mean by a median county is it's a county that's right in the middle. It's a typical county. And in a typical county, the primary care capacity in Texas is about 64%. And you'll say, I said the statewide average is around 86%. Why is it a typical county is so much lower? Is because a typical county in Texas ends up being much more rural, a smaller county, those places where the primary care access and capacity are the weakest. In general, the larger, more urban counties have more primary care physicians, have more capacity than the smaller rural areas. And part of it is because, you know, you think of what happens again in this county, or, you know, up in Dallas or Harris County or Bexar County, you know, they have medical centers there. There are other reasons why there are lots of doctors who are accumulating right in those areas. Whereas if you go just a few counties away, or even in some cases just one county away, there's a real shortage that occurs. So this is the map that we did that tries to show it. So you'll see what we call the adequate areas are pretty sparse. Those are the areas that basically correspond to places pretty much like you know, Travis, Austin, San Antonio, and Bexar County, Houston, Dallas. Some of the other areas, you know, some of those way up in the Panhandle area, it's not that they necessarily have a whole lot of doctors, but they don't have many people. So that's part of what makes it going on. But for most of the state, you know, if we sort of look at it, it's sort of, you know, pinkish reddish. Most of the state sort of falls into that category of being very underserved and severely underserved. It's particularly serious sort of along the border areas, but those deep red state counties are scattered all around the state. It's not just the border counties. It's not just West Texas. It's occurring in East Texas. It's occurring in Central Texas. It's occurring in North Texas. So it's all over the place. So some of the other findings is we also then tried to look at what was the primary care capacity for Medicaid and for low-income patients. And by the way, one thing that I forgot to say was that in addition to looking at sort of doctors, nurses, et cetera, another factor that we considered was actually the presence and the number of patients being served by community health centers. And so community health centers are places that specialize in serving low-income patients, the Medicaid and the uninsured type patients. So they help provide a lot more access for the Medicaid type patients. So the statewide primary care capacity is a little lower than the statewide average. It's around 85%. In the hearing that I was just at, people kept on saying that 31% of Texas doctors accept Medicaid. I don't know if this is exactly right or not, but nonetheless, it's a different thing to say sort of what's the capacity and how many are taking Medicaid, because of course, if you say, for example, your community health center, they don't necessarily have a whole lot of doctors, but almost all their patients are low-income patients and Medicaid patients. They are still providing lots of capacity, even though the number of actual providers at those facilities may be relatively small. There where all the uninsured, or where not all, but a lot of the Medicaid and uninsured patients can turn to get for care because they're part of the safety net. They're designed to do those things. So what we did was we tried to look at the impact of health reform. And for this, we used the estimates that Drs. Klein and Murdoch at the Hobby Center used in terms of the changes in insurance status. And again, what we assume is that when people have insurance, they are now demanding a little bit more primary care, about twice as much primary care. So that changes how we're viewing the supply and demand situation. Again, we assumed at this point that both Medicaid would be expanded and the health insurance exchanges would go into effect. Obviously, if there is no Medicaid expansion, that change in insurance status is going to be somewhere in the middle, somewhere between right now what it is and what the maximum levels that were being projected by the Hobby Center. So the situation if there's no Medicaid expansion will be somewhere in the middle. Now, in the short term, it tightens primary care capacity. So we found that average state capacity would decline from 86% to 80% after full expansions. Now, this is really sort of assuming that the state did nothing whatsoever to try to boost primary care capacity. And that's part of the underlying message in this report, is there are things that Texas could do to build that capacity. So, part of the thing to bear in mind is the needs of people aren't necessarily going to change very much, but if more are insured, the demand for care will go up. Now, on the other hand, that's in the short term. It tightens from the primary care capacity. In the long run, the situation might be a little different, because part of the reason that there are these shortages, particularly in certain areas, is because of the high uninsurance rate in Texas. It's hard to maintain a medical practice, a viable practice, if a quarter of the population or more in your county can't pay you because they're uninsured. So to the extent that we see health insurance expansions, this sort of increases the number of paying customers who can, possibly help sustain a medical practice. In that regard, in the long run, an insurance expansion helps build primary care capacity, both in the state in general, but particularly in the areas that right now have the highest uninsurance levels. It helps bring more things in. It's sort of like if you think about it in areas where there are movie theaters. Movie theaters want to be located where there are lots of teenagers. So it's equivalent, saying, gee, we're suddenly increasing the number of teenagers in an area. Guess what? There'll be more movie theaters built there. So, this is why there can be, some long-run improvements in primary care capacity that will occur. Whereas the look that we had really was saying, if Texas did nothing, this is just what happens in the short run. So the other thing that had been mentioned in other studies, and I know that there was a nice study that was done sort of looking at the economic impact of Medicaid, and in fact, we're doing a number of studies right now in 9 or maybe it's 10 states looking at the economic and employment impacts of Medicaid expansion, is that Medicaid expansions will have other positive effects in terms of improving employment, in healthcare in particular, but also in other sectors of the economy. You know, it tends to increase employment in construction and real estate and so on and so forth as well. So in the short run, what can Texas do? So there's certain things that Texas can do to try to make the situation somewhat better for building primary care capacity. One thing many people have noted is that there's a shortage in residency slots. So Texas is graduating more people from medical school than it has residency slots. So if they can expand the number of residency slots, particularly in primary care, you can help equalize that situation. Medicaid has a very nice transformation waiver that the federal government approved, and some of the intent already is to try to do things like building up capacity in Texas. So Texas is moving in the right direction already. It can continue to do these things even more so. There's the need to increase the supply and the use of both nurse practitioners and physicians, and to improve retention in those professions. So again, you know, some of the things with physicians, when you begin physician training, it takes a number of years for physicians to move from the day they begin medical school to the day that they can actually practice. Nurse practitioners and PAs, it's a shorter pipeline. So not only are they sort of less expensive, but they can be mobilized faster. Texas can bolster funding for federally qualified health centers to help in the underserved areas. There's already some support in the Affordable Care Act to increase the number of FQHCs across the country. Texas could do more also. This is particularly important because what happens is health centers are by their nature required to be in areas that are medically underserved, so to serve the populations that are the most vulnerable. And again, the need to focus on the underserved areas really is important. And obviously, if you do fund Medicaid expansions, it'll help support some long-term investments for primary care. And I think that's it. So there's the full report, though I guess there's a copy of it outside. If any of you want to contact me, there's my email address. And Ann or Ed, I'm turning it back to you.
We can see if anyone has any questions they want to have while you're standing up here. I see a couple of hands already. I'll start with this gentleman.
From a policy perspective, given that your estimates of Texas shortages in primary care are relative to the national average, was there any attempt to say nationally there is a short? You know what I mean? Is there any study that says nationally we could use 10% more across the board? So there's some baseline figure to which we can attach these 80%, 86% figures.
Well, you know, what I'll say is people quibble about, it's often said that there's a national shortage, and what I think people would certainly say is there's a shortage in many, many areas of the country, and then in fact the shortage will become somewhat worse as primary care physicians begin to retire if they're not replaced. The problem has been, for example, in recent years, an increasing percentage of med school graduates are saying, oh, I don't want to go into primary care, I want to go be a specialist. And so if you have a bunch of the primary care docs retiring and not being replaced, then the shortage becomes worse in the future. Is there a shortage now? I think there is, but again, there are people who sort of quibble about it. To give you a sense, though, of sort of perspective, in the U.S., about 1/3 of doctors are primary care doctors and about 2/3 are specialists. If you go to other developed countries in the world, it's just the reverse. It's about 2/3 of primary care, about 1/3 are specialists. So we've set up a funny system in the U.S.
Well, one of the reasons I said is that because, like with nursing shortages, you know, you can attract with incentive people from areas where there's less of a shortage, areas where there's more of a shortage. In other words, if there's a total shortage across the entire country, then attracting people from out of state is a difficult thing to do. But if there's an abundance in certain areas, there may be a way to incentivize by movement and transfer into that.
Yeah, certainly there's more supply in other areas who could be incented to move to the U.S., as well as trying to do things to sort of build up the supply by training more, and again, also by retaining more. And, you know, partly I mentioned sort of improving retention of of nurse practitioners and PAs who sometimes have relatively short, working careers. Actually, it's true for physicians too. I mean, sometimes physicians, sort of decide at a certain point they'd rather move into an administrative area, or frankly, even move into something like real estate instead of being a physician, or a practicing physician. So to the extent that we can attract people to stay in service, serving patients, whether they're doctors, nurse practitioners, or PAs, that helps, and they have a wealth of skill and experience that serves them well.
Go ahead, sir.
Okay, I mean, I know Texas does not have a benchmark healthcare system, but you said there were 35 counties that had adequate coverage. I would assume that covers a lot more than the 30% of the counties. What percent of the population does that?
I must admit I don't recall that number off the top of my head, but you're right, because they tend to be sort of the bigger, the counties like Travis County, well, even Travis isn't all that big, but like Harris, Dallas County, Bexar County, you're right. So the percentage of the population that sort of lives in an area with adequate primary care capacity is better. But, the overall situation in the state is still, pretty grim. Now, the other thing that I'll mention, of course, is that, we basically did the study is based on sort of where the doctor practices. Well, people do travel. I mean, so people will, come in for care. If they can't find a doctor in their county, then, they'll drive to the next county to get care. So there's some border crossing that occurs already. But it's clearly the case that there are many areas of the state where there are serious shortages. And I think, people in many cases say, gee, if you have to leave your county to go get care, and unless you're right on the border of the county, it's a problem. It's an issue.
I think we'll take just one more. Oh, I'm sorry. Krista, since you haven't had a question yet.
I'm just wondering where the Medicaid reimbursement rates for providers fits into all this discussion, because in the appropriations hearings that I've sat in around Health and Human Services, there were numerous providers coming up saying, we want to serve our community, but we're going out of business because of the dismal reimbursement rates, and how that fits in this access to primary care, especially if more folks are to be eligible for Medicaid.
Well, I mean, that's the good news about the fact that the Affordable Care Act included some provisions, at least on a temporary basis, to boost primary care payment rates in Medicaid to bring them up to Medicare levels. How much is that going to increase the likelihood that doctors are actually willing to serve Medicaid patients? Is still something that people are trying to figure out. Most of the studies have suggested it should improve the capacity a fair amount. Still not perfect. Part of the thing that will still be issues will be things like, well, gee, can you sustain this in the long run over a longer time period, as well as what happens if the doctors are simply in the wrong place. Then, if the doctors are all in a sort of wealthy area of the state or of town, it still will be hard for low-income patients to get to them.
Well, I wanted to set Dr. Koo free, but he's not running out of the building, so we may have opportunities for additional questions if they come up.